I would like your all's input on how you manage patients who are refractory to lenalidomide and discuss the role of the OPTIMISMM data.
So this actually is a great question, Donna, because we are all struggling with that concept. We are all trying to find this information in all the trial, in the relapse refractory, and some of them have some percentage of patient I would say exposed to LEN, but very few of them are the relapse and the one they are progressing on LEN. And I think the optimism comparing to, I'm thinking even the castor, for example. So if you think about the optimist trial where POM in combination with Valkendax has been used, these patients, I think they are all 100% LEN exposed, but 70% of them were actually refractory to LEN. This is something, for example, even the castor, they only have 30% of them. So I think the optimists give us some answers specifically to answer your question, because there are more patients in that group. The other thing about the optimism that in my mind is important to keep and in a way telling us what we already have said earlier, that we should use our best therapy right away. Don't wait later, because the PFS, you can get 10 more months if you go from 10 to 22 months if you use it really after one prior line. So I think we have some data we can take out from the optimism. They are obviously important. But we all need probably more, and we should probably try to find this population.
What about when you think about the optimism, so PVD versus DVD, and the benefit that you're going to get, and thinking about the cost implications as well? Which one, given what we have for first-line therapy, and if you use Rev up front and then you progress, which one is going to be where you think we're going to go?
I would say, with the castor data, I was never really too excited about, because I'm thinking how the way the two drugs data in combination with PI as you mentioned earlier, we all know that IMiDs is the best partner in combination with the data. So I was a bit disappointed to see, but not surprised though, to see that PFS that was, if it's the best 17 months, but it's not the 44, it's not that not reach in some group of patients. So I think it's important to keep in mind. But the question also specifically, how many of these patients were really refractory to LEN? Very small percentage in the cast. So I think the optimism is much higher group of patients.
I think you're right. I agree with your points. I think the OPTIMISMM data look particularly good after one line of therapy. And really, I think in Canada, that'll be the area that we're talking about. And exactly the question you asked: should you use PVD or DARA-VD? And if you're, data-minded, I think the data sits with OPTIMISMM, as you said, because that's the population that we'll be treating with previous R, now refractory to Revlimid, and that fits best with that trial. I think the attention though in Canada will be our approval for daratumumab is in combination with either lenalidomide or bortezomib. If you use PVD and continue the bortezomib to progression, that patient may not be eligible for daratumumab in the future. I think some people will be considering that. And one option is to not use the Velcade to progression. Stop at some point, whether it's 12 or 18 months, and hopefully the patient still benefits. But Donna, what do you think?
Yeah, I think PVD is the well-designed trial to deal with patients progressing on Revlimid more than any of the other trials. But the way we're funded, if you are of the opinion that all patients should have access to a DARA combination, it's not clear that that's going to happen. I mean, if you have someone that, let's say, gets Cyborg-D, a transplant, Revlimid maintenance, progresses, and you elect to give them PVD and hope that they'll get where they stop the bortezomib for however many months, then you're getting three courses of bortezomib. Now we have refunding now, which is good. But I think you know, again, this is one of those situations that I hope is fairly temporary, you know, with the isatuximab and pomalidomide data coming out. And I think the 014 data where patients who are on Revlimid and then after 1 or 2 lines of therapy can get Pom-Dara-Dex. That's a very promising regimen, not funding. I think all of us have, in the old days, managed to put these regimens together. So we all have experience with them, and I think we're comfortable. I mean, now that they're funded, we all have to, are not funded, we have to follow the rules.